Thank you for giving me the opportunity to join you virtually today. I'm very honored to be included in this plenary session, and I'm sorry that due to unforeseen circumstances, I can't join you in person. But I'm very excited about this session, and I look forward to reflecting back over what's happened in the past 10 years. So our starting point is the PHS revisions of 2012. And so let's think back. What was happening in 2012? Well, on the East Coast, we were reeling from Hurricane Sandy. And other exciting news, President Barack Obama had gotten reelected, and a number of TV shows had recently gotten canceled, including Gossip Girl, Punk'd, and of course, My Life is a Lifetime movie. So lots of memorable occasions in 2012. But I think what was foremost in our mind was this impending implementation of open payments, which was at that time just a proposed rule. So there are lots of details left open to be negotiated and lots of things to be debated. At that time, many of us took our hand at trying to forecast what was going to happen, and I did the same. So published a commentary, which I dug out for this particular session, and this could be vaguely embarrassing, but I will go through a few of my predictions and we'll see how I did. And perhaps in your discussion, you'll also see how you guys did in terms of your predictions. So what did I predict? The first thing I predicted was that firms would respond by targeting non-covered prescribers. So open payments covered physicians, but there were other prescribers, nurses, pharmacists who weren't covered by open payments. And so I felt that firms might respond by continuing their promotional activities, but diverting it towards people who would not be reported in the database. The second prediction I made was that firms would probably underreport unless there's really something about CMS's system of auditing that posed a credible threat to their honest and complete disclosures. And the third thing I predicted was that, given the institutional constraints of the health systems, patients and insurers really lacked the strong ability to sanction, by which I mean not visiting physicians, not paying physicians who receive payments. And because they lacked this ability to sanction physicians who did receive payments, there would really be very little deterrence effect. So how did I do? So what actually happened was, in fact, we did see some diversion of promotional activity towards nurses as well as other providers. And in fact, in open payments, in 2021, open payments expanded the set of covered recipients to include physician assistants who prescribed, as well as a variety of nurse specialties who also prescribed. Currently, though, pharmacists are not included. I was pretty wrong about the underreporting. Hard to know why. There doesn't seem to be evidence of any of that, although, of course, there very well could be. We wouldn't really know. But one aspect is that CMS probably did more reporting or more auditing than we had anticipated, given that the rules didn't really mention anything about the frequency or the demands of the auditing process. So that's been refined over time. And finally, did we see deterrence? I would say I was kind of right, kind of wrong. The parties in the healthcare system really are still constrained in terms of anything that they can do in terms of sanctioning. But what we've seen is that the number of physicians receiving payments has been declining over the years. And there's been some anecdotal evidence that physicians haven't been accepting payments, primarily because they're concerned about whether their names would be in a public database. So there does seem to be some deterrence effect. Some things we didn't predict, but maybe should have. One is that we didn't predict that consumers would just not make a lot of use of the open payments data. And we should have predicted this because HHS has had a number of transparency initiatives for nursing home quality, hospital quality, and frankly, patients just don't use them. What we found in our survey published in BMJ Open was that about 4% of the US population that was surveyed, a nationally representative sample, knew whether their physicians had received any payments. This was before open payments. After open payments, about 4% knew. So in terms of knowledge, it didn't really seem to have that much of an effect. One thing we really did underestimate was the super, super important role of mediators, especially given that patients themselves weren't accessing the database. Their knowledge about open payments and about industry payments was really dependent on these mediators. So I'm speaking in this context primarily about journalists who are able to access the data directly, aggregate it as they must because there are a lot of physicians and they're reporting summary measures. And they also focus on outliers. So for their stories, they focus on physicians who are receiving a lot of payments. One of the consequences, unintended consequences of this is what we've documented in one of our papers, looking at the effect of disclosure on public trust. Now, there's a huge political science literature, which basically says that actually transparency of an institution increases public trust. What we found in this case was that disclosure was associated with a decline in trust in physicians and in medicine as a whole, as well as a decline in trust in people's own physicians, even though nothing had changed in their knowledge about whether a physician had received an industry payment or not. We conjecture that part of this is because there was no, in this case, there was no big institution, the government, that was increasing transparency. The government was essentially forcing pharmaceutical companies to disclose. So it didn't really benefit from the improved public trust that often comes when institutions embrace transparency. And the third related area that we didn't quite predict was how third parties and how frequently third parties would use public data. So that certainly includes the government, and the Department of Justice has been using open payments a lot in their fraud investigations to first initially identify sketchy payments relationships. And you can see this in the complaints that are filed. And then key TAM whistleblowers are also using it to buttress their own cases. And we've seen, as you and Helen, I'm sure will lead the discussion, are well aware institutions are using open payments as well as journals to supplement some of their information. And now in looking ahead, what could we predict? So far, my record is just so-so, but I'll take a crack at it. One thing that's on our plates and on our minds, standardization and harmonization, super important, and a lot of really great work being done. The downside is we do have to start thinking about the compliance burden, or perhaps we already have, thinking about what the compliance burden would entail for that, for both institutions and physicians. The second thing I worried about for the future is, does disclosure normalize conflicts of interest? We've seen this again, drawing information from the political science literature, that once, for example, once campaign contributions were required to be disclosed, then people generally became inured to all the dollars that were flowing into the system. It was just generally part of the background. So I wonder if the disclosure and all of the aspects of the policy supporting disclosure could make people generally inured to conflicts of interest. And finally, as we go to this next stage and as we're getting comfortable with this new policy, the roles of public and private stakeholders will change, and we will need to work together in a different way. Certainly, the government was a prime mover for the PHS regs for CMS open payments. And certainly we're seeing with the DOJ and their investigations, but lots of private stakeholders as well, your institutions, universities, research institutes, grant agencies, both public and private, journals, and then the broader healthcare system, insurers, physicians, and researchers. And I didn't put it here, but also, most importantly, patients. We all have a stake, and we all have different goals and different incentives that do need to be coordinated. And so my sense is that given all the stakeholders, there really does need to be a third party, public or private, to coordinate the different interests and to make sure that we're moving in the right direction. So to my mind, that's probably the biggest challenge facing us in the future. And I look forward to continuing this discussion with you. I'm sorry to have to miss the lively discussion that I'm sure you all will have, but I hope to be with you next year. Thanks for the opportunity to join you.